Hi, my name is James Walsh. I'm a consultant trauma and orthopaedic surgeon working in Beaumont and the National Orthopaedic Hospital in Kappa. And I've been working in the sports surgery clinic for the last 7 or 8 years now, since 2015. So my talk this evening is going to be a bit of a whistle-stop tour around the foot and ankle. We don't want to get too much into the weeds on this, but just to augment what David's been saying and hopefully add a few other conditions that we might talk about also. And I'm going to talk about common conditions that we might operate on in foot and ankle surgery. So just to give you an overview, we're going to start off with ankle instability, probably the most common thing that happens in foot and ankle surgery. I'm going to talk about classic sprains, high ankle sprains, which really refers to a thing called the syndesmosis that I'll explain in a few minutes. Then we're going to move to the Achilles tendon and talk about tendinosis or inflammation of the Achilles tendon. I'm going to talk about a thing you may not have heard of called the plantar tendon and how much that causes a significant amount of apparent Achilles problems. And we're going to talk about Achilles tendon tears. We're then going to move to the posterior aspect, or the back of the heel, which is the source of a lot of pain for a lot of patients. And we're going to talk about that before moving deep into the actual ankle itself to talk about ankle impingement at the front and at the back, and then talk about deep ankle degeneration or osteochondral defects. We're then going to talk about plantar fasciitis, bunions or hallux valgus, and then finish off with just a bit on big toe joint pain. And then we'll summarize our findings and there'll be time for questions afterwards. So to start off, ankle instability. We all saw this recently at the French Open. Alexander Zverev had a severe ankle sprain and actually underwent surgery in Germany about 2 days ago for this injury. So you can see this is a pretty extreme version of an ankle sprain. But most of us have done this. We've all torn our lateral ligaments at some stage in our careers. So I suppose the question is, who needs treatment for this and what exactly is happening? Well, this is a classic inversion injury, and conservative management is the mainstay of treatment. The vast majority of these people will never present to a surgeon and certainly never need surgery. A ligament called the anterior talofibular ligament is the most commonly injured ligament here, and that spans from the fibula to the talus, and that's why it's called the anterior talofibular ligament. There's other ones, such as the calcaneofibular ligament and the posterior talofibular ligament, but we don't really need to worry about those. The anterior ligament is the one that's most commonly torn and is the one that is most commonly a problem. So what do we need to do with these? Well, in the initial phases, the classic rest, ice, compression, elevation works very well for the vast majority of patients. NSAIDs, that refers to non-steroidal anti-inflammatory drugs, so drugs such as diphenhydramine, Vimovo, Arcoxia, and basic analgesics such as paracetamol works really well. I find a combination of oral anti-inflammatories and analgesics and topical anti-inflammatory gels works really well for the majority of patients. In terms of intermediate things, in patients that aren't really settling down acutely, well then physiotherapy is the mainstay of treatment for lateral ligament injuries. You can consider injection therapy if you need to, but other adjuncts such as an Aircast A60 brace, I find really useful. I prefer these to the soft neoprene braces that you can buy in most pharmacies. This brace is available online. It's also called an Andy Murray brace because if you notice his ankles, he wears them when he's playing tennis. And it's a semi-rigid brace that comes in 3 different sizes and it's site specific. And it's really useful to augment physiotherapy. It doesn't replace it, of course, but it's a very useful thing to use for patients who have ongoing problems or aren't getting over the line with physiotherapy. So in terms of surgery, if these modalities don't work, what can I do if a patient is sent to me by a physiotherapist or by their general practitioner? Well, if the above modalities haven't worked, then we're going to perform an ankle arthroscopy. And that's where we make 2 small incisions at the front of the ankle, usually under general anesthesia, and look inside the ankle with a camera and see and assess any joint problems. If I need to stabilize the ligaments, I'll have to make an incision on the side of the ankle, and then I'll use 2 suture anchors, which are metal anchors with some stitches coming out of them that I can use to stabilize the ligaments. Or I can use a product called an internal brace, which is a much stronger construct. And I'll use that sometimes in patients who have really severe ligament injuries, or in certain patients who aren't suitable for just suture anchors. So moving to a different part of the ankle, this is called a high ankle sprain. It's a slightly different mechanism. You can see from the injury we showed you previously, when you roll or invert your ankle, you get one type of ligament injury. This ligament injury is higher, and it's called a high ankle sprain, and it's between your tibia and your fibula. And this is referred to as the syndesmosis, which is the joint at the top of the ankle. These can be a lot trickier to diagnose, and the history is really important. You can see from this picture below, there's a tackle going on here, and it's a dorsiflexion, or the ankle going upwards, and rotating externally. This is the type of injury that will cause a syndesmotic injury. An X-ray can easily miss this, and it's actually more of a clinical or MRI diagnosis. If you're in doubt, we'll sometimes have to put a camera in and just check anyway, because these much more commonly need surgery than do a lateral ligament repair. And what surgery can we do for them? Well, the most common thing, again, is we put a camera in, an arthroscope, and have a look inside the ankle and see if there's any other pathology. And then we can use a product called a tightrope, which is a simple band with 2 buttons on it that brings these 2 bones together and repairs the ligament indirectly. And it works really well in the vast majority of patients. So who needs to see a surgeon if they've got a lateral ligament or ankle ligament injury? Well, again, as I said, the vast majority of these patients never need an operation. So it's only for patients with ongoing instability despite non-operative modalities. Patients will often say, I just don't trust my ankle. I've had physio for 6, 8 sessions, and I still don't trust my ankle. Ongoing pain. Do they have high ankle pain? This is something that the physios would send to us quite regularly. And do they have associated deep ankle pain? Because that could suggest to you that there's something more sinister going on. And that might prompt either a basic X-ray or indeed an MRI scan. So moving to the back of the ankle to look at the Achilles tendon. We're all familiar with the Achilles tendon, but it's actually made up of a number of different muscles. Your gastrocnemius muscles, the pear-shaped muscle at the back of your calf, and your soleus muscle, which is a bigger, thicker muscle beneath that. And they form together to form your Achilles tendon. You can't talk about the Achilles tendon without talking about the posterior chain, or the posterior kinetic chain, as we often refer to it. And that goes from your gluteals, the biggest muscle in our bodies, in our backside, our gluteal muscles, then our hamstrings, then the gastrosoleus complex, as we refer to those muscles as. This then becomes the Achilles tendon, sweeps down the back of your heel to become your plantar fascia. So it's all connected in one big long chain, and we call it the posterior kinetic chain. Why is that important? Well, it's implicated in a whole heap of ankle, hindfoot, midfoot, and especially forefoot conditions in the foot and ankle. And it can help us to treat or help us to diagnose a lot of problems in these areas. So we always think about this when we're looking at it. And especially with the Achilles, you need to think about this. So Achilles tendinosis, or inflammation of the Achilles, again, physiotherapy is the mainstay of treatment. You can use an ultrasound guided injection as an adjunct. Got to be very careful in this region. You don't want to blindly inject it because you can cause problems for the tendon. This is what a more or less normal or slightly inflamed Achilles tendon looks like. And this is what a much thicker or more inflamed Achilles tendon looks like. With these, the vast majority of these do not require direct surgery for Achilles tendinosis. Those that do, we often see a small area at the back, and it's on the middle or the inside of your Achilles tendon. If you have Achilles tendinosis and you've got pain in your Achilles, if you palpate the middle side of your Achilles tendon, this might be the most painful area. And if this is the case, it can often be this tendon called your plantaris tendon, which is what we call an accessory tendon. It doesn't really have any function, so we've kind of evolved out of it essentially. It's a very small and rather insignificant piece of anatomy, but it causes a lot of irritation. And if this doesn't settle, we can inject the area with a high volume of local anesthetic, or we can debride it as a day case procedure. And in patients with Achilles tendinosis in this region, this surgery works extremely well. Moving to Achilles tendon tears, something a lot of patients with Achilles tendinosis are terrified they will get, but actually only about 3% of people will rupture an Achilles tendinosis tendon. This usually presents as a sudden pain in the Achilles. And despite popular belief that this is because you didn't warm up, it actually usually occurs relatively late in the activity and rarely at the start of activity. This needs urgent assessment. If you think you've ruptured your Achilles tendon, you shouldn't wait around on this. If in doubt, if you're not sure, it needs urgent soft tissue imaging. The mistake to make here, if you've had a sudden sharp pain at the back of your Achilles, usually during activity, don't get an X-ray. An X-ray isn't going to help you here. An ultrasound or an MRI scan is the diagnostic imaging of choice. But an experienced clinician, be they a physiotherapist, primary care practitioner, or an emergency department doctor, should be able to diagnose this quite easily without any imaging. So what can we do with these? Well, we can manage them non-operatively, provided you catch them early, and that's why it's important to catch these early. If you do catch them early, you have the choice of non-operative versus operative modalities, and open surgical repair can be considered. Why do we do this if we can manage them non-operatively? Well, they have similar results in the long term, but you've got a faster return to activity and a lower chance of re-rupture if you repair it surgically. And it's a very safe and reliable procedure. If you don't treat this, or you don't realize that you've had an Achilles tendon, because no one wants to rupture their tendon, so we'll often pretend to ourselves that we've had a sprain. What can we do for these? Well, they're usually seen late on, about 3 months, usually in a more elderly population. What we do is we lie the patient down in the bed, we take a look at the back of the patient that you can see here, and on the left-hand side, you can see a chronic tear, and on the right-hand side, we have a nice, healthy-looking Achilles tendon. We can still manage some of these non-operatively, but the majority of these would be offered operative modalities, provided they've nothing else that means we can't operate on them. And actually what we do with these tears, you can see this chronic thickened area in the Achilles tendon on the left. We take the tendon from your big toe, called your flexor hallucis longus, and we reroute it through the back of your heel. And this works really well for these patients, but it isn't quite as good as your Achilles tendon, as you would imagine. What do we do to rehabilitate these? Well, it doesn't matter which way, whether you treat them non-operatively or operatively, you need to manage them with early active range of motion. And we start this at 2 weeks and progressively decrease your heel raises over the next few weeks. But generally, patients will wear some form of heel raise for about 3 months after surgery. Moving to the back of the heel, posterior heel pain. Another thing that's commonly sent to physiotherapists and even orthopedic surgeons at an early stage. What's going on here? Well, it's either the Achilles tendon, as we've seen previously, as it inserts into the calcaneus, your heel bone, or it's a little bursa, which is a fluid-filled sac behind your heel. And it's either in front of the Achilles, in which it's called a retrocalcaneal bursa, or it's a subcutaneous bursa, as you can see in this case, this photograph on the left-hand side. Again, these can be treated with rest, anti-inflammatories, some physiotherapy, and injections under image guidance. But sometimes it's caused by a bony problem. And this is called a Haglund's deformity. You can see this rose thorn appearance of the Haglund's at the back of the heel. And you can see this essentially eroding into the back of the Achilles tendon. And this causes a lot of pain and a lot of difficulty. Typically, these patients won't respond well to physiotherapy. And when they do get to see us, they're really in quite a lot of chronic pain. The treatment for this is primarily surgical. And what you do is you actually lift the Achilles tendon off the back of the heel, again under general anesthesia, reconstruct it and shave the bone away that's impinging at the back of the heel. And then we reconstruct it using a thing called an Achilles speed bridge, which is a really strong product and works really well and has radically changed our management of these conditions. A bigger injury than an Achilles tendon irritation, and it needs longer time to rehabilitate. This will take you at least 6 months to settle down from. So when do I need to see a surgeon with regard to my Achilles? Well, if you've got long-term irritation, physiotherapy hasn't worked here. Chronic limitation of activity in terms of normal domestic tasks or recreation, or indeed work tasks. If you think you have an acute Achilles tendon rupture, don't delay. Go to an emergency department if you think you've ruptured your Achilles. Of course, if you can see your primary care practitioner or you've got a relationship with a physiotherapist, it's very reasonable to see them, provided they can act on it quickly and either send you to get imaging or send you to an emergency department if required. So moving deeper into the ankle to look at ankle pain, we're going to talk about anterior and posterior impingement. Pain is anterior at the front of your ankle, and you'll have decreased dorsiflexion, meaning you've decreased the ability to move your ankle up. You won't complain of deep pain unless there's a coexistent deep degenerative injury, and we're going to talk about those in a minute. And the treatment for this is primarily a camera, an arthroscopy, and we resect these, but sometimes we have to perform an open resection of these injuries or these problems. Moving to the back, well, there's loads of causes for this. You might have heard of things called an ostrigonum or a stieta process, and essentially these are just bony outgrowths at the back of the ankle joint. An MRI scan is very useful, as is a clinical examination, and the treatment of these depends on the underlying cause. And again, in the majority of cases, we can treat these non-operatively with injection therapy and physiotherapy, depending on what's going on and what's causing the problem. Moving deep into the ankle joint, I'm going to talk about osteochondral defects just very briefly. The talus or the talar bone forms the bottom part of the ankle that lives beneath the tibia. And an osteochondral defect of this is a defect in bone or osteo and cartilage, chondral. Again, these are commonly caused by inversion sprains, people going over in the ankle, and you get what's called a kissing lesion, where one bit of bone bangs off another bit of bone, and it damages and erodes the cartilage. Patients will complain of deep pain, particularly pain after activity, and it's typically on the middle side or medial side of the ankle. It's often, as I said, associated with an inversion sprain and a history of a lateral ligament injury. And classically, these are patients who really just don't settle down with physio and have ongoing deep ankle pain. So again, initially with these, we immobilize patients, give them non-steroidals and analgesia. We can try an image-guided injection. And if those modalities don't work, then we can go in and have a look with the camera, and you can see here our tibia, normal talus, and you can see this little rim here, and that's an osteochondral defect. So when we resect this, we take away the cartilage, we actually put holes into the bone here, and that stimulates cartilage to regrow. Not quite as good as your original cartilage, of course, but it does settle down a very significant number of patients. These are quite tricky things to treat though. So when do I see a surgeon if I've got deep ankle pain or decreased range of motion? Well, ongoing limitation of movement despite physio, analgesia, and ongoing deep ankle pain. That suggests you might have arthritis or an osteochondral defect. Moving further south, we're going to talk briefly about plantar fasciitis now. Extremely common, and nobody gets any credit for this. It is extremely debilitating, as anyone who has this will tell you, and it's often undertreated. Classically, patients get early morning pain, or they get pain in their heel following prolonged sitting or driving. And when they initiate activity and get up from a seated position, whether they're driving or sitting at their desk, it often eases a little bit with activity while you get up in the morning and brush your teeth, settles down, but then it comes back later, particularly during prolonged exercise. And that's because of inflammation in the plantar fascia. I see this as a symptom of a bigger problem, and typically the big problem here is the posterior kinetic chain, as we talked about earlier. It's tightness all the way up, and this is the weakest link in the chain causing pain. Often we'll get referrals for heel spurs on X-ray, and it's really important to note that these bear absolutely no relationship to the presence or indeed the absence of plantar fasciitis. So what can we do to treat these? Stretch the posterior kinetic chain. That's the underlying problem that's causing this, emphasizing the calf muscles that we talked about earlier. A simple heel raise will work really well, an off-the-shelf one you can buy in Boots for €5. Custom orthotics are really rarely indicated for this. Oral non-steroidal anti-inflammatory drugs. You can try ibuprofen over the counter, or you could get prescribed Arcoxia or Vimovo or even Difene. Massaging the plantar fascia with your big toe extended works really well. And I find the easiest way to do this is to actually cross one leg over the other and use your hand to massage a tennis ball or golf ball into the area that's painful, and extending your big toe tightens this and makes it a bit easier to do. Injections, we're commonly referred patients to see can they get injections, and I always say, well, have you tried all these other modalities before we think of that? Because the vast majority of these patients will settle down with non-interventional modalities. PRP has been trialed extensively for this, and there's very weak evidence to support this, and I don't typically use this in the vast majority of my patients, because simply put, it hasn't been shown to be any better than injection therapy and indeed non-operative modalities. Shockwave therapy will sometimes be used by your physiotherapy for this and has some evidence when used for about 3 sessions. So when do you see a surgeon if you've got plantar fasciitis? Well, surgery is almost never required for this condition. This is an entity that should be treated by physiotherapists or sports medicine practitioners with non-steroidal anti-inflammatory drugs, a simple heel raise to just settle symptoms down while you're engaging with physio. And injection therapy should only be considered as an adjunct. It's not a primary therapy. And equally, custom-made orthotics are almost never required for plantar fasciitis. And they won't solve it if you haven't solved the underlying architectural problem. And that's primarily physiotherapy and stretching. So moving on to the front of the foot, we don't have time today, unfortunately, to talk about the various conditions in the midfoot. I'm going to talk briefly about hallux valgus or bunions. So what is it? Well, it's an angular deformity of the first metatarsophalangeal joint. That's your big toe joint. About 90% of these are female at the time of surgery. You can see this is a nice significant bunion. The mean age of surgery is 60, but this is getting lower all the time. And many people start young and progress. Most people will have bilateral or both-sided bunions, but with differing magnitudes. So how do you manage these? Well, you can either operate on the shoe to fit the foot by getting a wider shoe, or the foot to fit the shoe. And usually it's a combination of both things. So who gets non-operative management in these? Well, people with a mild deformity, mild symptoms. Normal footwear, obviously this isn't normal footwear, so within reason. Patients who don't want surgery, or they can't have surgery, and we can use spacers in these kind of patients. Some patients will come to us with corrective bunion correctors, that they've used and bought online. Please don't buy these. They do not work. So when do I see a surgeon for hallux valgus or bunions? Well, if you've got pain, difficulties with normal shoes, this isn't an operation to allow you to wear 10-inch stilettos to go to Tesco, nor is it reasonable to be going to a wedding wearing Birkenstocks. We're looking for a patient with reasonable expectations who's having reasonable problems in normal footwear. Second toe problems, often second toe or hammer toe, the problem is caused by the bunion, and the hammer toe is really a secondary symptom of this, but it can be seriously debilitating. Transfer metatarsalgia, well, what is that? That's pain over your lesser metatarsal heads or overload. And you can see there's a thick callosity at the bottom of this patient's second foot. But the problem here is actually being primarily caused by the bunion, and that's what needs to be treated along with the second toe. Cosmesis, should you get this operation done because you don't like the appearance of your bunion? The answer to that is categorically not. Don't get this done for a cosmesis. So in terms of operative management, well, the typical surgery before this is called a scarf osteotomy, which is an open osteotomy, and it works for most bunions. It's very stable and strong, gives a very powerful correction, and you can weight bear on day one post-op. You wear a shoe for 6 weeks, and note that swelling can take at least 3 to 4 months to settle down, but it's got a very high satisfaction rate. The crucial thing about bunions, before we move on to big joint pain, is that while they're progressive, they're very slow in doing so. And not everyone progresses past a certain point. So if you're not bothered and you're wearing normal footwear to do normal things, you do not need your bunion corrected. So in terms of our final topic, we're going to talk about big toe joint pain, or first metatarsal phalangeal joint pain. It's also called hallux limitus or hallux rigidus, because we like making Latin sounding names in medicine. The vast majority of these are treated conservatively using anti-inflammatories, rest, modifying your footwear. Orthotics can be of benefit, but in very limited circumstances. And you can see there the picture here. There's a big bony spur on the top of this toe with a big inflamed toe. And this is painful, particularly when anybody dorsiflexes or lifts up their big toe. So what do I recommend? In terms of running shoes for forefoot problems, I really like Asics glide rides. They've got a very nice curved forefoot, but your foot actually sits quite straight in these. And I find they work really well for patients who like walking or even like jogging, and work really well for these because they allow you to move forward without actually raising your big toe up. Hoka runners or Brooks runners are also good, but in any running shoe you're looking for, you need to look for a good solid heel counter, a supportive midfoot, and then I like these curved forefoot running shoes. They work very well. So when should you consider surgery? Well, when non-operative modalities fail. A chelectomy is the surgery that we would typically use for these. And what we do is make an open incision under general anesthesia of the joint, and we take away the impinging bone and soft tissue, as you can see in the middle picture. And then the lowest picture shows the improved range of motion in the joint. Again, it's a day case procedure, and 4 to 6 weeks in a post-operative shoe, depending on what we see inside there, and about 10 to 12 weeks, depending on what's been done and what other problems are in there inside in the joint. Are there replacement options? Yes, there are. But unfortunately, they haven't been the panacea that we've thought they would be. You can get half a replacement, put in a joint toe spacer in the middle, or even a total joint replacement option. And while we've tried and looked at these, they work in limited conditions in limited numbers of patients. And surprisingly enough, the most effective treatment for big toe joint arthritis, when it gets to severe end-stage arthritis, is actually this, a fusion. Most patients are horrified at the idea of getting a fusion until they actually get it. And it works really well in about 94, 95% of patients. You stiffen the joint with a plate and screws, and it's been the gold standard for a very long time at this point. It's very reliable, allows patients to wear normal footwear and a heel of about 1.5 inches, but the toe doesn't move again, and that's important to note. However, it's a really effective operation. So when do I see a surgeon if I've got pain in my big toe? Well, if you're having problems in normal footwear, and as I said, this isn't an operation to wear very high heels, but it's not unreasonable to want to walk into somewhere like Arnott's, a big department store, and say, I'd like to buy a nice normal pair of shoes. Reasonable behavior for reasonable feet. If non-operative modalities have failed, and if they're affecting your everyday work or recreational activities. So in summary, There's loads of different pathology around the foot and ankle joints. That's why we like being foot and ankle surgeons. It requires a multidisciplinary approach, and predominantly one of physiotherapy, intermittent use of orthotics, and podiatrists. New strategies in surgery work really well in conjunction with non-operative modalities. And when non-operative interventions are unsuccessful, there are multiple operations available in the Achilles, the ankle joint, the ankle ligaments, the hindfoot, and indeed the forefoot. And have a high patient satisfaction. Thank you very much.
James, thank you for a very good talk. It's a very comprehensive talk as well, and I'm sure you covered a lot of topics in that. We'll have answered a lot of the questions, but we still have a lot of questions to answer. So Grania has osteoarthritis in her foot. X-ray shows severe wear and tear at the joint between the front ankle and the foot. Doctor says it's not time to have surgery. She's 63. She feels like a cripple without taking opioids, and she doesn't want to get hooked on them. But can she opt for surgery herself, and what is the success rate and recovery time?
Okay, well, it's obviously, hi everyone, it's very difficult to know exactly what's going on in terms of, depends where the arthritis is in the foot and how severe it is. Between the foot and the ankle probably means that it's in the midfoot, which is a very common area in what we call the second and third tarso-metatarsal joints. So around this area of the foot in the middle of it. There are loads of options for that, including non-surgical ones like orthotics, injections, and some physio to strengthen up the area as well. And that's usually our first protocol for those type of things. So it may not actually be time for surgery. In terms of getting checked out, it's very reasonable if you've got a lot of foot pain. And if you're up to the point where you're taking opioids to counteract your midfoot pain, then I think that's time to get checked out and time to at least get weight-bearing views of your foot and ankle, and maybe even MRI of the foot. And that'd be something to consider getting referred on by your GP. And we don't take direct referrals in the sports surgery clinic from patients. We do take them from physiotherapists and podiatrists and from GPs. But if you're having ongoing pain, that's to the point where you're taking opioids, I think it'd be worth having a chat to your GP and say, listen, this really isn't working for me in terms of non-operative modalities or further investigation modalities. And I'd like a referral to somebody to see about getting a scan, or maybe the GP could get a scan and further investigate it. And I think I would at least be looking at getting some physiotherapy, getting a physio to assess your midfoot and see where you're at with that. Because really, in terms of long-term opioids, I'd certainly agree with that. I don't think they're a solution for anybody's foot pain in the long term. Okay?
Thanks. John, here's a bunion question. He said, how bad should you let a bunion get before seeing a consultant? Is early intervention a good idea or not?
Thanks, John. It's a key question. It's something I say about 20 times a week. Bunions are progressive. They get worse with time. I think I said it in my talk there. Not everyone progresses past a certain point. And simply put, if you're managing in normal footwear to do normal things, you do not need your bunion operated on. You will not wake up tomorrow with bunions like your mother, your grandmother, your dad, or anybody else in the family. They're progressive, but they're slow in doing so. Early intervention doesn't really make much of a difference to it at all in terms of the surgical plan. If you let it get really far, over decades, you might get arthritis or degeneration, and that might change the surgical plan to a fusion, which is a very acceptable way of treating a bunion anyway. But in terms of early intervention, if it isn't bothering you and you're living a normal life, doing normal activity, wearing reasonable shoes, you do not need anything done to that bunion.
Thanks, James. Okay, Olivia, how long does recovery take after an ankle fusion? Example, how long have you to non-weight bear for?
So it all depends on how you're getting it done. Some people do these arthroscopically. I do them via an open procedure because I think it gives a better fusion rate and it's a stronger construct. We use a large plate and screws at the front of the ankle. So the ankle will be fused with a plate running down the front here like this, and then screws go directly across the ankle like that. My patients, and there are two other foot and ankle surgeons here in the sports surgery clinic. I think we probably all are quite similar with our post-op plans. My patients are non-weight bearing for the first 6 weeks, but you can rest your foot in the ground to balance. Then after that, for the next 4 to 6 weeks, your weight bearing is tolerated in a boot. You can expect swelling for about 4 to 6 months, depending on how the ankle goes. And it takes about a year for it to fully settle down. It's important to note when you're getting an ankle fusion, this is a big operation in a small place. It takes about twice as long to do an ankle fusion as it does to do a hip replacement. So it's a much bigger operation in terms of recovery. Pretty much anyone you go to, I would imagine, would keep you non-weight bearing for 6 weeks post-op.
Okay, thank you. how likely are you to develop arthritis after successful ankle stabilisation surgery following multiple inversion incidents and torn ligaments? Is it a given that it will occur at some point in the future?
Hi, Bridget. No, it's absolutely not a given. The most commonly injured ligament in the entire body is called your anterior talofibular ligament, and that's on the outside of your ankle, near the skinny bone on the side of your ankle. And if you've had that reconstructed and there's no damage to the dome of the talus, here, this is your talus bone here. The ligament on the side of your ankle is running along here, called your anterior talofibular ligament. That's the one that's most likely torn and the one that's most likely been repaired for you. If you don't have any degeneration inside the ankle joint, you're not at any increased risk of getting arthritis in that joint. If you did have degeneration in that at the time of the injury and maybe it needed to be fixed at the time with an arthroscopic procedure, then yes, you do have an increased chance of arthritis in the future. But just for an isolated ankle ligament, no, there's no increased risk of degeneration once it's been stabilised and successfully stabilised.
Okay. Sean, what can be done if you've no cartilage left in your ankle?
So there are a number of options. It really depends on what your activity levels are and what you're doing on a day-to-day basis. It could even depend whether you're working in an office or you're going up and down a ladder and standing around all day wearing work boots. The first thing you can do, non-operative modalities would include injections, anti-inflammatories, and supportive braces. And these can go up from just a simple supportive brace to custom-made boots and custom-made footwear. Moving to the surgical side of things, it really depends on if all the cartilage is gone. Well, then you're down to two options. You either fuse it or you replace it. So there's two schools of thought on this. Replacement is the future. I don't personally think that it's as good as I would like it to be yet, so I don't currently offer ankle replacements, but I'm hoping to do so within the next couple of years when better replacement options come out. The long-term results for me just aren't quite there yet. They're almost there, but they're just not quite there for the vast majority of my patients. So if I have somebody who is very keen on looking for an ankle replacement, I'll refer them on to one of my colleagues. But in terms of my practice, where I see patients with severe ankle arthritis, I would generally offer them a fusion. Now, obviously, that depends on age, activity, and so on as well.
Okay, thank you. Recovering from plantar fasciitis on the right foot, attending physio, improving 7 weeks ago, very slowly improving. How long should I continue before considering a cortisone injection? Previously had 2 injections in both big toes for arthritis. Also, can I return to running? That's Caroline.
So plantar fasciitis is one of the most common entities that we have, one of the most common entities that's referred to us. And as I said in my talk, I think plantar fasciitis is actually dealt with best by physiotherapists. So they're the ideal people to see it, and then secondary on from that is the sports medicine team. In terms of injections, if you've had a dedicated course of physio for 6 to 8 weeks and you're still not winning, I would think then you're coming very much to the point where an injection into the plantar fascia is a very reasonable thing to do. I personally don't recommend blind injections on this unless you really are very experienced doing them, because the mistake can be that you inject into the heel pad, and I would never inject into that area there. You need an ultrasound guided injection or preferably an image guided injection. But if your GP is very comfortable doing plantar fasciitis injections and he or she has done them for a long time, that's a reasonable thing to do. I think when you're getting to the point that it's 6 to 8 weeks and it really isn't progressing with physio, then I'd start thinking that an injection is reasonable to get. It's not a fun thing to get, but it's good to augment physio. And it's really important that it isn't a replacement for physiotherapy. It just augments it. It makes it easier for you to engage with the physiotherapy. And that's what really settles down plantar fasciitis.
Okay. Laura, 20 years ago, she had bilateral crush fractures to both calcaneus, bilateral fractured talus on both feet, crush fractures, dislocation of the left talar navicular joint. She's pretty active, she walks, runs, but often has pain. How long will it take for injury joints to fuse without triple arthrodesis?
Well done, Laura. That's a fantastic result 20 years after severe injuries like that. I'm amazed that you can run. In terms of the injured joints fusing without a triple arthrodesis, they're very unlikely to fuse spontaneously at this point, and we don't really see that much in post-traumatic patients. We see it sometimes in inflammatory arthritis conditions like rheumatoid arthritis and psoriatic arthritis. Patients will spontaneously fuse, and over time we can resolve their problems themselves effectively. In terms of it fusing by itself at this stage, it's almost guaranteed not to fuse by itself at this stage. Got to say, it's very impressive that you're running and walking and doing this level of activity without any surgical intervention at this point. It's unlikely to fuse at this stage without any surgery, you know.
Thanks, James. Tina, How do you know it's plantar fasciitis? Do you have a scan or an X-ray? How do you diagnose it?
So for me, plantar fasciitis is a clinical diagnosis. It's very easy to diagnose clinically. You just press on the bottom of the foot. If you look at the bottom of the foot underneath your arch of your foot, if you go on the middle side where your big toe is, if you lift up your big toe, you'll feel a band running along underneath your foot, just around about here. Everyone thinks it's a tendon, but it's not. It's your plantar fascia. And your plantar fascia is just a thick bit of tissue that binds up all of your muscles. We have fascia in all of our muscles in our body. And for obvious reasons, it's thickest in your feet and in your hands, because that's where we put our hands and our feet on things. So if you feel the band here and you work your way back towards the heel, and just as you join up to the heel, that's typically where you'll get the majority of your plantar fascia. It's called your medial plantar band. And it's really a clinical diagnosis. An MRI is of use, but really we use an MRI to see what it isn't. We're trying to see, is it something else, like a rarer cause of pain around that region, like a stress response in the calcaneus or a rare condition called tarsal tunnel syndrome. X-rays aren't really any good for plantar fasciitis. They're a very good broad view of what's going on in the foot and ankle, give you a good idea of the architecture. And I'd always stress when I'm talking to people who are getting an X-ray, make sure it's a weight-bearing X-ray. You need to know what the foot's doing when you're standing on it. People often get referred to us with a plantar calcaneal spur, which is just a little bump just there. And the presence or absence of a calcaneal spur on the bottom of your foot bears no resemblance to the presence or absence of plantar fasciitis, and it is essentially a useless point. I have no interest in whether or not somebody has a plantar calcaneal spur, because it doesn't make any difference as to whether or not they have plantar fasciitis. So in summary, this is really a clinical diagnosis for me. I think an X-ray is a very useful, weight-bearing X-ray is a useful way to see, is there anything else globally going on the foot and ankle? And if you're really not sure that it's plantar fasciitis, an MRI is a useful way to confirm your diagnosis or to tell you that it isn't something else.
Okay, thanks. Dimpna, nerve pain under the heel bone, stabbing like an electric shock, what can be done?
Nerve pain under the heel bone.
Sharp and stabbing like electric shock.
Sounds much more like plantar fasciitis. There's rarely, there's Baxter's nerves, rare nerves. You can get rare neuropathies around the heel, and you can get nerve pain, true nerve pain in the heel. Much more likely it is plantar fasciitis. As I said briefly when I was answering the last question, you can get a thing called tarsal tunnel syndrome that can give you pain around the heel, but by far the most common cause of pain in this region is plantar fasciitis. And the other thing would be that you can get a stress response or stress fracture even of the calcaneus, and that gives you that severe sharp pain. And plantar fasciitis is really important that it gets no credit. This drives people absolutely insane. It's extremely painful, extremely debilitating. And the problem with it is, if you're sitting behind a desk for hours all day, you get up out of your desk with plantar fasciitis, you're limping. But if someone sees you 15 minutes later in Tesco, you look like a fraud because you're walking around without a problem, because plantar fasciitis settles down very quickly after you get moving. And then as you move for longer during the day, as anyone with plantar fasciitis will tell you, their pain becomes more prominent as your inflammation rises later on in, say, an hour of walking. Around the heel, it's much more likely to be plantar fasciitis. If you think it's nerve pain, it would need to be diagnosed by somebody. Usually that would be diagnosed by a thing called a nerve conduction study, which would be rare that it would be in the heel.
Here's a lady who did have surgery on her bunion on her left foot, and she said now looks like her big toe has moved into the next toe. Is there anything she can do? Yeah,
so I see, Jane, you had surgery years ago for your bunion. Yeah. One of the potential complications of a bunion is recurrence, that they can come back and the toe can drift back in. And if that does, you can get revision surgery for a bunion. It really depends on how much has moved back in or how far it's moved back in and which has happened. Has there been a failure of the bunion, which is actually quite rare? Often they'll drift. You'll see someone's bunion and at the start it sits like this, and then after about a year it moves into this position here. And that's normal. You want that to move into there so it accommodates a normal shoe. So you can wear a normal shoe you might buy in Arnold's or somewhere else. If it's moved right in and crossing over the other toe, it may be that you need a revision procedure. And that can be something as small as just doing a small procedure to the toe to bring it back out. Depends what this bone here, the metatarsal, is doing. So if you're having trouble with that, I would say go back to your surgeon, get a plain film X-ray weight bearing of the foot and move on from there, because revisions they're rare, thankfully, but they're very straightforward in the vast majority of cases.
Okay, last one. This lady says she's demented from metatarsia. Is it ever surgically treated?
Yeah, absolutely. Metatarsalgia is something we treat quite commonly. So by metatarsalgia, these bones here are our metatarsals, and the bones at the bottom of the feet is really where you get metatarsalgia. So you've got bones underneath your big toe. You've actually got two small bones here called sesamoids. We won't get into that. That's a little bit more complicated. But the most common place you get metatarsalgia is in your lesser metatarsal heads. And the most common place you get it is in your second and third. And what this is typically actually caused by, and you saw in my talk, posterior kinetic chain tightness. Again, if you think of your foot here and you think your gluteals way up at the top, your backside, if they're tight, your hamstrings are tight, the muscles in your calf are tight, and then this causes a pull on the heel, and that drives the foot into the floor. Now, there are some other conditions you can have with the shape of your foot that can lead you to have metatarsalgia, but that's the most common cause, tightness. And that can be alleviated by physiotherapy. One of the other things that can be done for metatarsalgia is to get a metatarsal pad or bar, and this should be fitted by a physio. Doesn't need a custom-made orthotic. Almost never needs a custom-made orthotic. You can get one done, but you should start with non-custom orthotics, because a lot of the time you just get a simple, basic, off-the-shelf orthotic and add a little pad. And the crucial thing for it is not to put the pad where the pain is. That's the most common mistake that we all make because it's sore. But actually, if you think about it, you just focus the pressure on the area that was under pressure. So what you should do is move the pad behind, okay? So that's your physio to stretch that out, the posterior kinetic chain, to offload it with a pad. If it's very painful, you should get a plain film x-ray to see is there any arthritis or anything in that. You can check as well, because another thing that can give you pain in this is a thing called a Morton's neuroma, and that's most commonly occurring between the third and fourth toes. And it gives you kind of burning, stinging pain. It can also be described as a numb pain, which I know sounds quite counterintuitive, but the reason you've got that is because you've got damage to a nerve there. So the information going back to your head is garbled. So you get this horrible sensation of, I've got this burning pain, but it's there, but it's not there, and it's really hurting in the bottom of my foot, but when I go to press on it, it's kind of not there. And that's actually a great explanation of nerve pain. So metatarsalgia can be caused by pressure, or it can be caused by nerve or degeneration in the area there. So what I would do is, if you've got metatarsalgia, my first protocol would be to a physio and see what can be done from that point of view. If that's not working, the next step would be to get a plain film x-ray and maybe go see somebody from a foot and ankle point of view, and you may need an MRI scan prior to getting anything done. But there's lots of surgical treatments that can be done for that, such as shortening the bones, injecting them from a non-operative point of view, and even if it's very arthritic, you can replace the lesser metatarsal phalangeal joints, and they're very reliable because they don't take a lot of load through them, and replacements work really well if you have to do that in that region. So there's lots of treatments, both non-operative and operative, for metatarsalgia.
James, thanks for joining us tonight, and thanks to everyone else who's joined in.